Hello, this is chapter 9. Okay, so we have done a bunch of chapters that have been really long lately. This one is not as long, so you should be happy about that. Today we are going to talk about two different categories here. We're going to talk about dissociative disorders, and we're going to talk about somatic symptom disorders. Now, soma, as we've mentioned before, means body. So these are body symptom disorders, okay? And dissociative disorders we will also discuss here, okay? So starting with our dissociative disorders. If you think about the root of the word dissociate, if you were to disassociate yourself with yourself, there you go. Sounds funny. Okay. So major forms of dissociative disorders. We have this dissociative identity disorder. Now, dissociative identity disorder used to be called multiple personality disorder. And often you'll hear people refer to it as that, even though it hasn't been called this officially in a long time. It does help us kind of conceptualize what this is. This is when an individual develops more than one self or more than one identity. Okay, so the idea is, and if you've seen movies on this, the movie Sybil, the movie Three Faces of Eve, these are really, honestly, they're very upsetting, they're very disturbing movies, but they are your classic, well-known movies on multiple personality disorder, or now, as we call it, dissociative identity disorder. Now, the reason that I do mention that they are disturbing is that there is a lot of abuse that is shown in these movies, and abuse of children, okay? Now, again, these are not documentaries. These are, Hollywood movies. So well, they were done well for what they are, so they are disturbing. The idea is this. The idea is that somebody who has dissociative identity disorder has had a lot of trauma in their lives. A lot of trauma, typically by those who they were supposed to trust. Okay, so a lot of abuse, physical, emotional, sexual abuse by people they were supposed to trust, caregivers, things like that in their lives. And the idea behind this disorder is that it's so upsetting that they sort of develop these different personalities that protect themselves from some of these memories. Maybe you have a personality who is just the child and has the child voice and acts like a child, and you have a personality of, a strong male figure who protects and doesn't take anything from anybody, and you have a different personality that is nurturing and this and that. Some people talk about the quote personalities not communicating with each other or knowing about each other, and other people talk about this in a way that they do know about each other and they do communicate with each other. This is a really interesting disorder, and let me tell you one of the reasons why. This is a really interesting disorder because some people really believe in it and some people really do not believe in it, and other people are kind of in the middle of the road. What we kind of see is that someone who has had a lot of trauma by people they were supposed to trust are also people who as adults are very suggestive. And so one of the theories is that if someone goes to see a therapist who is very interested in this disorder, if the therapist starts asking leading questions and starts getting excited when the person talks about these multiple personalities and displays this person versus that person and asks to talk to this person or that person, this individual's they slowly meet more and more of the criteria for dissociative identity disorder. So one of the theories is that you have a highly suggestible person who goes to see a therapist and sort of with that positive reinforcement from the therapist, then displays these things. One of the reasons that we have this theory is this. Dissociative identity disorder is a diagnosis. Most therapists have never seen it. I've never seen anyone with this disorder. I don't know that I know anyone who has seen anybody or diagnosed anyone with this disorder. Therapists who are interested in this disorder and specialize in this disorder have a large number of clients who have this disorder and are diagnosed with it and display these symptoms. Okay? If you follow me there. So, again, though, it may be that people with this disorder seek out therapists who believe in it, and people with the disorder, don't see therapists who they're not sure if they would believe in it. There's a lot of possibilities here. Okay? So that is why this is sort of a controversial diagnosis still. We have criteria for it. Most people will never see it. Some people might call it something else, right? So maybe if I see somebody who's had a lot of trauma, I am going to more likely lead to a PTSD diagnosis or, talk about attachment issues or discuss those things. And so maybe I may lean more toward that, but somebody else may lean more toward this diagnosis. And, who knows? Or maybe not. Maybe it's just that we haven't had the chance to see somebody who comes in that we say, wow, okay, I finally get it. This is a real thing. Okay. So within this, we're going to talk about a couple other things within the dissociative disorders. Okay. Dissociative amnesia. Okay, this is when somebody has an inability all of a sudden. Okay, so it's not a dementia. With a dementia, they would slowly lose the ability to remember. Amnesia would be all of a sudden an inability to remember important personal details and important personal experiences that are associated with a traumatic or very stressful life event. Okay, so again, this isn't all of a sudden this person doesn't remember things. It usually comes back, right? It's usually sort of in the moment trauma. If you've ever experienced something intense or traumatic that you've witnessed, you may sort of have that feeling of like you can't see exactly right, or things may be in slow motion, or it feels different. That's a slight dissociation. This would be a more dramatic version of that, okay? Now, this amnesia can be diagnosed with a specifier of dissociative fugue. Okay, this is the word fugue. So you'd have dissociative amnesia with dissociative fugue, or without fugue. Okay, that's that specifier. Now, a dissociative fugue is where someone sort of kind of loses track of who they are or what's going on or anything, and they wander. I always imagine people ending up in cornfields, right? And that is, they just sort of end up wandering or driving, and they don't know where they're going or why. And they find themselves somewhere and sort of all of a sudden, typically kind of coming back to who they are and thinking, oh my gosh, how did I get here? What happened? Similar to sleepwalking, but not sleepwalking. Now, this is again something that happens for a very short period of time and typically after something traumatic. When you see these shows or movies where somebody, completely forgets who they are for long periods of time, that does not happen. Usually things can be triggered back where they're like, oh yeah, I know who, I'm good. I don't know what happened. That was weird. There's been a couple cases of celebrities who have claimed to have experienced dissociative fugue. You can look that up. But there was one, now I can't think of her name, of course, right? But one woman who ended up in someone's backyard naked or something like that. And when they found her, she was like, I don't know what happened. They, you know, blamed it on a dissociative fugue. And that was that. There was somebody else a long time ago who ended up like robbing a store, who had no business robbing a store. And again, they blamed it on a dissociative fugue. Now, who knows if that is true or not, but I just find it interesting. There are people that really do seem to experience this. Okay, the next disorder. Please remember, if I go through these things too quickly, to pause me and then start me. So the next disorder is called depersonalization, derealization disorder. Okay, depersonalization, derealization disorder. I will want you to know the difference between depersonalization and derealization. So let's go through that. This disorder is a dissociative disorder in which the individual experiences recurrent and persistent episodes of depersonalization or derealization, or both. Okay, so again, to be different from dissociative amnesia is like a one-time, in-the-moment thing. This disorder is that it happens recurrently. Now, depersonalization. Okay, this is this condition where people feel detached from their own body. They feel like things are not real. They feel like their body feels deformed, but not in a body dysmorphic disorder way, but in a, they feel like maybe their body is all of a sudden weirdly formed or shaped, or their skin feels weird, or they look down at their feet and their feet seem strange, okay? But it's detached from their own body. And then also sometimes people talk about, with depersonalization, maybe watching themselves from outside of their body kind of thing, okay? Now so that's depersonalization, okay? So thinking about it as the person, it is you, it is your body that feels weird or wrong, okay? Now, derealization is a condition when people feel a sense of unreality, right? So as though the world is unreal, or detachment from their surroundings. So all of a sudden you feel like the couch looks weird, or the air feels or looks weird. Now, this is not the same as a hallucination, but because you are aware that it is odd, and you're not seeing something that's not there, except that you're seeing it as unreal. Maybe you see it as sort of wavy, or you see it as it seems, I don't know, like see-through-ish, or just odd. I often think about movies where they are trying to give you the idea of what it feels like if you were on certain drugs, and the tones and the voices that they use are sort of kind of things. I hope you know what I'm talking about. Otherwise, I sound fairly odd. But that sort of like, where you see things in the movies that way, or you hear them that way, okay? So again, depersonalization is your own body. Derealization would be those surroundings. Okay, so what do you do? Well, okay, so the dissociative disorders, with dissociative identity disorder, the goal is to what you call integrate alters. Alters is the word that they use for the different personalities. Okay, so the child alter and the man alter and the this alter. So the idea would be the goal is to integrate them, to make somebody feel, and this I'm fully supportive of, right? We want to make that person feel whole. We want to make that person feel confident in themselves as a whole human who deserves to have the same rights as others and to be treated well by others, okay? Some methods that are used are hypnotherapy. Hypnotherapy is sometimes a good idea and sometimes a bad idea. The reason that it is a good idea is if somebody is a pulled together person and they want to relax their brain and they want to sort of have a meditative session. It is a bad idea if you have somebody who is highly suggestive and you have a therapist who's not cautious. Okay, if you do a hypnotherapy where you're looking for, quote, repressed memories, if anybody ever suggests, if you're ever in a therapist's office and they want to, have you relax and talk about repressed memories, please leave the office, okay? Repressed memories can so easily not be repressed memories. They can so easily be suggestions by the person that's doing this, so the therapist or whoever it is. And then once it's in your brain while you are relaxed, it sort of creates a memory that wasn't there. So maybe it's something that happened, but there's a good chance it's not something that ever actually happened, and now you believe it and you remember it, and they have you talk about it until it's a solid memory. That's a really scary thing, okay? So especially if you're somebody who's highly suggestible, under hypnosis, which hypnosis is just a deep meditation, okay? You can't be hypnotized if you don't want to be. You can't all of a sudden be in a meditative state unless you want to be, okay? But if you allow for that, the potential of suggestibility is a problem. Now, because the potential of suggestibility is there, hypnotherapy for things like, I don't know, smoking cessation or feeling better about other things, that can be a very much a positive, right? Like, oh no, they're going to suggest that you don't want to smoke cigarettes anymore. Like, that seems okay. But if we're talking about, did someone harm you as a child or not, that's, I think, not good. Okay, cognitive behavioral techniques. Again, learning how to deal with these things, how to identify when is it happening, to identify how to really notice reality from what's going on, how to, learn sort of breathing and pulling yourself back into reality, those types of things, okay? Treatment from dissociative disorders often involves not only the disorders themselves, but really we end up treating the associated or comorbid disorders, right? So we find that as we treat the anxiety, as we treat the PTSD, as we treat the depression, these disorders dissipate. They go away, okay? And I think if you stop and think about that, it should kind of make sense, right? These strange, odd feelings dissipate as you treat what might be the core problem. Okay. Now we're going to talk about somatic symptom and related disorders. Okay. Somatic symptoms, or body symptoms, right? So somatic symptoms involving physical problems and or concerns about medical problems, medical symptoms. Okay, these are our somatoform disorders. Somatoform disorders. Somatic, Greek word for soma, meaning body. I say that so many times so that it sticks in your head. Okay, the first one that we're talking about here is called somatic symptom disorder. Somatic symptom disorder involves physical symptoms. Okay, so actual physical symptoms that may or may not be accountable by a medical condition. Okay, so if we can say, yes, this is due to a medical condition for sure, then it's not a somatic symptom disorder. It is a medical condition. Okay, the reason that we say may or may not be is because sometimes we call it this, and there actually is some kind of medical condition. We just don't know what it is, and we can't seem to figure it out, and no physician seems to be able to figure it out, so we call it this. Okay, now we also though see maladaptive thoughts, feelings, or behaviors that are present. Okay, people with this disorder think to a disproportionate degree about the seriousness of their symptoms. And that is more the problem, right? They feel extremely anxious about the symptoms. They spend an amazing amount of time and energy on the symptoms or their concerns about their health. Okay, so even if it is likely due to a medical condition, it would still be a somatic symptom disorder if they were like overly ridiculously upset and anxious and worried about it. Okay, so maybe like, oh, this is a ridiculous example that popped into my head, but like if I had, a poison ivy rash on my hand, it's technically a medical condition, right? However, if I decide that it is, going to make my hand fall off and I don't go to work and I start thinking about like, what does this mean? And is it going to get in my bloodstream, and it's going to go into my bloodstream, and it's going to, I'm going to end up with cancer over it, and I don't sleep at night because I'm worried about my poison ivy for like extended periods of time, and even after it goes away, I'm still ending up breaking out in hives now because I'm so concerned about what that poison ivy might have meant at the time. Then it's a somatic symptom disorder. Okay, now often it is though something that is not caused by a medical condition. So often it is that maybe I am breaking out in hives because I've worked myself up so much that I've caused some sort of issue going on, or I am sick often with, I have, I end up vomiting, a couple times a week because I get myself so worked up and thinking about vomiting so much that I end up vomiting. And, because of the vomiting, I end up going to the doctor, and the doctor doesn't know what it is. So we end up doing testing, and we try to figure out what it is, and we can't figure out what it is. So they end up doing, their colonoscopy to figure out what it is. And it's still, we can't figure it out because it's actually just that in my head, I've worked myself up so much that I end up vomiting. That's a somatic symptom disorder. People who have these disorders, this group of disorders, tend to have very large medical charts. They end up at the doctor often, and they end up with a lot of testing being done because there may or may not actually be something that we can find wrong. And they over worry about everything. Now, there are some people who have very large medical charts and we don't know what's going on, and they don't have this disorder. It's just that we can't figure it out. Okay, so I don't want to lump everybody into that. It's just that people with these disorders tend to have that. Next one is illness anxiety disorder. You were probably more familiar with the term hypochondriasis, right? Or you're a hypochondriac. Well, the term we use is illness anxiety disorder. That should make sense. You should be able to remember that. Anxiety over illness. Illness anxiety disorder is a somatic symptom disorder characterized by the misinterpretation of normal bodily functions as a sign of serious illness. Okay, so maybe I have this gurgling in my stomach that happens several times a day. Normal bodily function, right? whether or not you like it. Now, if I decide that gurgling in my stomach or it leaves a little bit of a slight pain, I'm now going to Google, slight pain on the, lower left side of my abdomen. And I'm now then convinced that I have, wrong side. Anyway, maybe I've decided I have a burst appendix, or my appendix is on the wrong side and now that's burst. And I am, or I've decided that I have, some sort of intestinal issue. Maybe I have a tapeworm. Whatever, you can search on the internet, as you know, and you are going to be dying. Right? So if you put in any kind of weird random symptoms into a search engine on the internet, you will find at least one that says you have cancer and you are dying of something terrible. So the internet does not help people with illness anxiety disorder. They should not be allowed to get on the internet. Okay, people with this disorder fear or mistakenly believe that normal body reactions represent symptoms of a serious illness. Okay, so having a twinge, having this or that, probably means nothing. Now, we don't want somebody with this disorder to completely stop paying attention, because if something is wrong, we do want them to go to the doctor. But we have to teach them to stop and say, okay, is this a normal feeling or is this a problem? If I stop and sing a song or think about something else, do I still really notice it? If so, how often? But not to over obsess about it, right? Eventually, if it continues to be a problem after a certain amount of time, then we're going to check it out. Okay. The next disorder is really interesting, and this is called conversion disorder. Okay? It's also called functional neurological symptom disorder. Okay? Functional neurological symptom disorder, or conversion disorder. So if you think about conversion, converting, okay, it involves an individual experiencing a change in body function not due to an underlying medical condition. Okay, so clients with conversion disorder show a wide range of physical ailments. The first one that we have on here is pseudoseizures. Pseudoseizures are really interesting. I have seen somebody have pseudoseizures in my office, and I just remain calm. The person appears to be having a seizure, but is completely fine before that. They end up discussing something that is upsetting or intense, and they appear to have a seizure. You just want to make sure that they are somewhere where they're safe. So if they're, shaking somewhat uncontrollably, that their head won't hit something hard, that they won't actually injure themselves. But then as soon as it's finished, it's finished. And there's no aftermath of seizure. And, the first times that this happens, people do go to the hospital, and the emergency rooms can't see anything as to why they would have had a seizure. They can't see anything is wrong at all. And often these things are induced by significant stress and maybe discussing or thinking about something pretty terrible. Sometimes you have disorders of movement. Sometimes you have paralysis. Sometimes you have just weakness in the body. Interestingly, some people have disturbances of speech, so they kind of have trouble forming words. Sometimes people experience blindness or other sensory disorders. And sometimes people have cognitive impairments, so their brains aren't working as well. And I think most of us can kind of understand that, right? Where you have days where you're just like, my brain is not functioning right. Okay, but there's not actually anything wrong. Maybe days that you have trouble finding words or thinking as well as you usually do, and you just think, man, today is not my day. For other people, this is sort of a continuous problem that is not related to actual a medical condition. Now, I want to talk about the blindness for a minute, okay? So with conversion disorder, you see this every once in a while, where somebody who, like, they are, to their knowledge, blind. They truly believe that they cannot see. Okay, and so it affects their lives, right? You can't drive if you're blind. You can't read if you're blind. You can't do these things. Interestingly, though, okay, if you show somebody a picture, like let's say you held up a picture of a cat to somebody with this blindness, they would report not seeing anything. They would report not seeing anything, all that stuff. But then if later, well, let's go back. Let's say you showed them a picture of a cat with a hat. If later you then said, you know, did the cat have anything on it? Like, was the cat wearing shoes? The person would say, well, the cat had a hat. Okay, so the person is not blind. The person can see enough that it is processing in their brain, but the sight is not processing in their brain. I don't exactly know how to explain this any different than that, except that it's really interesting. Okay, and it's usually temporary. That is the blindness. Okay. So we also have these conditions related to somatic symptom disorders. Now, the first one is called fictitious disorder. So fictitious, like fiction, fictitious disorder imposed on self. Okay, so people fake symptoms or disorders. So they make themselves sick, or they shave their own heads. They do things for the purpose of some sort of external gain because of this inner need to maintain a sick role. So that is an individual who really enjoys other people taking care of them and other people feeling bad for them. So somebody may, like I said, they may shave their head and wear a scarf on it so that everyone else believes that they're going through chemo treatments or has cancer. And they will have people that come over and tell them how strong they are and tell them that they're praying for them and tell them all these things. And this person sort of needs this and loves this in a really unhealthy way. Sometimes people continue to make themselves sick so they stay in the hospital. Most people don't like being in the hospital. There are some people who love being in the hospital and love the sick role. And they end up with a lot of testing that's done and they would put themselves through a lot in order to maintain this sick role. And that would be the external gain. The external gain is people coming over and loving on them and bringing them food and telling them how strong they are. Okay, so that's fictitious disorder imposed on self. The next disorder is more disturbing, and that is fictitious disorder imposed on another. This has often been called Munchausen's, and that's what you've probably heard of before. Munchausen syndrome has been referenced in certain songs and things like that, but it was called Munchausen syndrome by proxy meaning by someone else. We now call it fictitious disorder imposed on another. And that is that an individual feigns an illness on someone else. So this is often, sadly, a parent. And so a parent may keep their child sick, just sick enough that they don't die, because if your child dies, then it's over. but just sick enough that they stay in the hospital. And again, other people come to the parent and say, oh my gosh, you're so strong and you're so brave, and I'm so sorry you're going through this with your child, and what can I do for you, and oh my gosh, and all of this. Again, that's that external gain that they get. Again, some people will convince their children that they are sick or that they have cancer, and they will shave their children's head, or they will. This is child abuse. This is imprisonable. Clearly, it upsets me very much to think about it, but it is an actual thing. Okay. Now, the term malingering. Okay, so malingering is a little bit different. Malingering is not an actual diagnosis used in the DSM, but malingering means lying, fabricating of either a physical issue or a psychological issue for some sort of external gain that's different than these other things. So the external gain is usually getting out of prison time, getting some sort of financial compensation. Okay, so people typically malinger, let's say, post-traumatic stress disorder in order to get compensation from the Veterans Association or the government. People may malinger having schizophrenia so that they can obtain disability services and not have to work. People may malinger that they have some sort of disorder so that they are not held accountable for a crime that they committed. Okay, so that's malingering, is lying about either, I just mentioned psychological things, but you can also malinger physical symptoms, right? But it's lying. It's not actually making yourself sick. It would be lying about being sick for those types of things. Okay, do know those words. Okay, and then we have conditions related to somatic symptoms disorders. So clinicians assume that clients engage in malingering in order to get this direct benefit or primary gain. Okay, so that is, the primary gain would be direct benefits of occupying the sick role. Time off, insurance, tangible rewards. Clients with fictitious disorder deliberately feign or exaggerate symptoms, and this is called a secondary gain, and that would be sympathy and attention they receive from other people when they're ill. Now, this is technically the terms, primary gain and secondary gain, but I will tell you this. When people talk about malingering and they talk about that, we use the term secondary gain. So for your future, I do want you to know that there are technically two different terms clinically, but I also want you to know that often clinicians just use the term secondary gain for both. Maybe we should all go back to school and read our books. But there is this. Okay. Just a couple more things here. So, theories and treatment of this. So we may use cognitive behavioral therapy to, again, stop and talk about, okay, what's actually going on? What do you notice? What is real? What is not real? Hypnotherapy, again, can be used in that kind of calming, breathing, learning to be okay with the way our bodies feel, learning to feel okay with different bodily sensations, and noting that they are just bodily sensations. Medication can help, and whether that is an anti-anxiety medication, antidepressant medication, something like that. And then people also use interpersonal therapy, and that is kind of talking about different relationships that people have, how they can improve certain situations in their lives in order to then not be so focused on the somatic symptoms, or to not need these somatic symptoms in order to feel okay or complete. Now, I wrote this down here with this fictitious disorder. I say no group therapy. Okay, so interestingly, for people with other types of disorders, a group therapy can be helpful, right? So you meet other people with the issue and we talk about it and we sympathize with each other and we feel empathy. Now, somebody with fictitious disorder, their goal of their disorder is to get empathy and sympathy and a lot of attention. So we say absolutely no group therapy for these types of individuals because that would just be encouraging it. What we really do for fictitious disorder is work with the people around them to say, don't give them sympathy for this. Like, do not respond to this. When they act healthy, respond positively to that. When they are doing well, respond positively to that. Okay? So we sort of change the positive reinforcement to healthy behaviors versus sick role behaviors. So the last thing that we have are psychological factors affecting other medical conditions. Okay? So this is a disorder in which clients have an actual real medical disease or symptom that seems to be worse because of psychological or behavior factors, right? So depression makes the pain worse. Stress makes the pain worse. Denial of a diagnosis, so therefore not getting treatment when needed, makes the condition worse. Engaging in poor or dangerous health-related behaviors, so drinking or using drugs when you need to be taking care of yourself, getting up and going on, a run every day when you need to be resting. I mean, that one's not as dramatic, but hopefully you get the point here. One thing I always like to note is when people end up with a cancer diagnosis, often people somehow blame themselves a little bit. And sometimes I've heard people say, well, if I hadn't been so stressed out, if I had just taken those days off that people suggested, blah, blah, blah. You cannot cause cancer with stress. You are not causing the cancer. It is not your fault in that way. Smoking cigarettes may cause cancer, but stress or working too many days did not cause your cancer. Having said that, being overly stressed and working too many days when you are going through treatment may inhibit your ability to heal well. It may affect your immune system, which you need to be strong during treatment. Okay? So these factors do play a part, but they are not going to cause certain issues like this. Now, when we talk about, we'll get to these. So hypertension, so we may see, chronic occupational stress increasing the risk of high blood pressure, right? Increasing the risk. Asthma, anxiety can cause this to be worse. Cancer, denying the need for surgical interventions. Diabetes, we work with when we're, unwilling to alter lifestyle. We're unwilling to monitor glucose levels. So that is when we work with people with diabetes. The biggest thing is compliance. And there are people that are just unwilling to comply to do the things that they need to be doing. Chronic tension headaches, definitely stressors are a big piece of that. Cardiovascular disease, refusing to visit a cardiac specialist, things like that. So a couple things to talk about here, and that is with stress and coping. Stress, in case you're not familiar with this, is the unpleasant emotional reaction a person has when he or she perceives an event to be threatening. Okay, if you've never experienced stress, that's weird. So we do have these different coping strategies. We can focus on the problem and changing the problem. We can focus on the emotion and change the emotion around the issue. So if the stressor is, my job is too stressful, problem focused would say, okay, Maybe we need to get you a different job. Maybe you need to start applying for different jobs. If you have to keep that job and changing jobs is not an option, then we need to change the emotion around the job and maybe change how you feel in reaction to the way your boss is talking, or how you decide how much emotionally you're going to invest in each day. Those types of things. Emotional expression plays a piece here, and we talk about emotional expression when we talk about in the schizophrenia type of stumble over words there, chapter, and that is emotional expression, meaning I speak really loudly about everything I think, and I am intense all the friggin' time about stuff, or I'm reserved and I'm calm and I'm this way and it is fine, or I'm repressing it and it is fine, but it's actually not fine. Okay, these different types of emotional expression can be a factor, and it's important just to discuss it. Now, personality style. Okay, we have two different personality styles that we do see related to stress and coping. I used to talk about these when I worked in a cardiac rehabilitation setting, and we'd have group therapy for people who were being seen for people have had some sort of heart event, meaning heart failure, heart attack, those things. Heart event. Your personality style and the way that you do things does affect how well your heart does after a heart event. Okay? So it may not cause the heart event, but after you've had one, you really need to probably make some changes if you have one of these styles. Now, type A is that people usually know what type A is, right? Intense, hard driving, competitive, impatient, easily irritated. They're going to be on time. They're going to do their homework in therapy session, not because they want to, because that's what they do. They do it all. They do all this stuff. Everything has to be perfect. That's exhausting and hard on your heart. Now, the type D personality is really interesting. So going back, people are usually familiar with type B. Type B is more laid back and chill and all lovely, right? Type D is this person who has very similar style as type A internally, but they don't express it. So type D is actually more critical when we talk about heart issues, because the type D person feels irritated and feels frustrated and feels intense, but they don't tell people. And so therefore they don't end up getting their needs met, which is even more stressful. Okay, so they're basically internalizing and feeling distressed, but not expressing it. Okay. So last thing here is that we have something called behavioral medicine. Behavioral medicine is this interdisciplinary approach to medical conditions. By psychological factors, it tends to be rooted in learning theory. Okay, but the idea is it's this interdisciplinary approach. So behavioral medicine groups are going to have physicians and psychologists and nurses and maybe a caseworker and different people. Within behavioral medicine, a lot of psychoeducation is involved, and that is teaching individuals about how psychological factors can affect their medical outcomes and affect their feelings around their medical issues, and therefore how and why they may want to make some changes. So I added this psychologists in the medical world. So as I've mentioned, I've worked in hospitals and radiation oncology departments and cardiac rehab departments and inpatient palliative care and things like that. At one of the places I worked, it was called health psychology. And that is, we focused on the health aspects. And in another place that I worked, they called it medical psychology. You can, The terminology is a little bit different. People would say they are a little bit different, but sometimes people use these words interchangeably. So it really depends on who you're talking to and how they feel about each specific term. But the idea is that you have psychologists who are helping in the behavioral medicine piece of improving people's medical lives. Okay. I think I'll leave it at that. That's all for this chapter. See you in the next one.